Basically, immune system is fighting against any enemy, including bacteria, virus. So without the immune system, we cannot survive
at all. So everybody has some own immune system. So, and then vaccine, measles vaccine, tetanus vaccine, stimulate the immune system to prepare for the enemy. The problem for the cancer immunotherapy is this guy is from your own cell. So very difficult to distinguish your healthy normal cell from and then cancer cells. So that's a challenge. Somewhat boundary is very narrow, so therefore, like an immune checkpoint blockade, if you give a medicine, sometimes you develop autoimmune reaction because cancer cell and your own cell is very similar. So that's a dilemma. So therefore, how to differentiate the attack against cancer cell from autoimmunity? So that's a kind of a future. All right. Can you move the slide, or
I can move it for you.
Can you try it? So. Again, I am going to talk to you about Immunocore, so I have to disclose this. I'm the site PI for Immunocore study, and we have probably 30% of the patient for that trial. So therefore, you have to think that this my talk may be a little bit biased. Okay, but I try to be very, Anyway. So this kind of a lecture to student. I hope that I have a pen. Here you go. So we just call this non-specific immunotherapy, cancer-specific immunotherapy, so-called blockade of inhibition. So this is kind of a general molecule which make your immune system angry. For example, if you inject the BCG into the cancer and immune system recognize BCG and then act against the BCG, but the cancer is there, so they kill the cancer cell. So, and then this adaptive immunotherapy that we are going to talk a little bit, NK cell, lymphokine active killer cell, these cells are non-specific. Just try to kill anything against foreign cells, for example, abnormal cells. So activating these cells and then infusing back to cancer patient usually doesn't work well. So oncolytic virus like a TVEC virus can infect the tumor cell and then kill it. Sometimes they just stimulate immune system non-specifically. So these are kind of general immune stimulation. Usually doesn't work. So you need more specific type of treatment. This is a cancer-specific immunotherapy. For example, cancer vaccine and cancer-targeted antibody like rituximab for the lymphoma, B-cell lymphoma, or these are against breast cancer. Bevacizumab anti-VEGF antigen antibody. So now you frequently hear the CAR-T or Tcell, T-cell receptor T or TIL. So these are more specific. CAR is antibody incorporated into the T-cell to recognize cancer cells specifically. So T-cell, TIL, tumor infiltrating lymphocyte, investigators believe that this T-cell know how to go, where they should go. They are from cancer sites, so therefore if you expand, maybe going back to cancer to kill it, actually recognizing cancer antigen. So these are more popular activity right now. So I'm going to talk a little bit. And then another kind of big field is immune checkpoint blockade. You see the CTLA4 antibody, ipilimumab, PD-1 antibody, nivolumab, Keytruda. Now we know that cancer cells smart enough to inhibit immune system by expressing or utilizing these so-called immune checkpoint blockade. I'm going to try to explain a little bit more easy way. But this IDO inhibitor, or this is another kind of inhibitory molecule in tumor site. Unfortunately, this study was negative, so therefore not many people are talking IDO right now. So this kind of baseline. Do you know these guys? Oh, you don't watch TV? These two guys, doctors, I have to respect, received Nobel Prize. Okay. This is Jim Allison, Dr. Allison, MD Anderson. This is Dr. Honjo, Kyoto University. Why they get the Nobel Prize? Immunotherapy, immune checkpoint blockade. Nobody believed this kind of immune checkpoint blockade is important. But not only melanoma, any kind of cancer, this is kind of a common blocking mechanism for immune reaction against cancer. So Jim Allison found that the CTLA4 molecule is important for anti-cancer immunity. Honjo find PD-1, PD-L1 interaction is important for cancer escape mechanism. All right, next. Can we go? Yeah. All right, now immunology. Difficult. And then also, I want to just you understand that this called MHC molecule. This is critically important. We keep calling it HLA-A2. Somebody think that is a mutation antigen. It's not. So MHC or HLA, human leukocyte antigen, is like a method to present your own self. So any cell which has protein, portion of so-called peptide, is going to express on the surface of this MHC molecule, HLA antigen, to be recognized by T cell. T cell had a T cell receptor. T cell receptor recognize this tiny peptide protein molecule on the surface of MHC class 1 or class 2, so-called HLA-A2, where it's class 1. So the immunocore medicine is this portion. So therefore, if you don't have a MSC, appropriate MSC, HLA-A2, it's not going to work. Doesn't fit. You are using a long key to the room. So therefore, HLA-A2 here is very critical to see the efficacy. So the commonly frequently asked question is, oh, I'm HLA, A3. Why not? Give it to me. But it's not going to work because this T cell receptor only recognize molecule on the very strict, type of the HLA. In this case, HLA-A2. So if a patient doesn't have HLA-A2, as of today, molecule so-called IMC GP100 does not work. You got it? Okay. So this is an important thing. And in addition, immune system need additional signal, so-called second signal. This is so-called the CD28 B7 interaction. This is a first signal. This is a very specific for individual cell. And then second signal is a co-stimulatory molecule. So this is very important. Then if immune system activated, it's going to be dangerous. If it's too much, going to kill your cells. So have to suppress. So there's no negative feedback, right? That is a so-called immune checkpoint blockade. If immune system is too much active, your immune system kind of behave, okay, calm down. So that's a molecule called the CTLA4. So this is a kind of a T cell activated, and then this start expressing it, and then this molecule has more binding capacity compared to CD28 molecule. So all of a sudden, this signal is good, but the second signal doesn't go. And then this CTLA4 signaling is kind of suppress the cells. So this situation, cell is angry. This situation, okay, just calm down, all right? Then a cancer cell utilize this system, so-called regulatory T cell, suppress the T cell, use this CTLA4 molecule to calm down any immune cells. Okay, then then molecule called the ipilimumab is developed to block the interaction between CTLA4 on the surface of T cell, and then this indicates cancer cell or other immune cell. So therefore, there is no break The immune system keep active, and then recognize cancer. Oh, this is cancer antigen presented by actually more very precise ways. This cancer antigen presenting or immune antigen presenting cell, but it's not a cancer cell. But once this is activated, T cell go to the cancer. So if a cancer specific T cell is activated, they produce the CTLA4 antibody molecule, and then block the hyperactivation. So by using an antibody, this cancer specific T cell keep activated. So that's a way. Also, the CTLA4 is expressed in an inhibitory T cell called a regular T cell. So therefore, cancer cell is smart enough to utilize these molecule or suppressor cell to suppress immune reaction. So therefore, if you block this interaction, this anti-cancer cell, T cell, is going to activate and then keep attack on the cancer. Okay, this worked for the melanoma first time, And why this is important? Because cancer immunotherapy 20 years ago, very safe, doesn't work. Yeah, this is kind of final resources for everybody. Okay, cancer vaccine, go there somewhere, Mexico somewhere, some general, non-specific immunotherapy. Doesn't work, but safe. But now you are using a normal immune system mechanism to keep immune system angry. So this system is not only anti-cancer mechanism, but also suppressing autoimmunity. So now you start seeing anti-cancer immunity. At the same time, many patients develop the autoimmune reaction, like colitis, skin reaction, thyroiditis, pituitary inflammation. So that's a dilemma. But now cancer immunotherapy is efficacious but toxic. Okay, so therefore that you have to understand. Immunotherapy, everybody like it, but it is toxic, potentially. Can you go to the next one? Yeah, this is similar mechanism, so-called PD-1, PD-L1 interaction. If T cell is activated, some of them produce CTLA4, and regulatory T cell express CTLA4. But at the same time, T cell activated PD-L1 molecule, express, and then cancer cell express PD-L1. It's a ligand to PD-L1, and this is a programmed death. If they interact each other, tumor cell is going to die. So then Honjo developed antibody, proposed antibodies to block it. By blocking it, T cell is not going to die. T cells survive longer. This is activated T cell which express PD-1, and the antibody block this area. And some of the tumor cells express the PD-L1 molecule to begin with. Again, now you hear MHC molecule. You start understanding it. So this T cell receptor on the T cell recognize small peptide on the surface of MHC molecule. This in the Immunocore case, HLA-A2. So, and then Immunocore developed this T cell receptor plus CD3 antibody fusion protein. So therefore, if patient doesn't have HLA-A2, it's not going to fit. Okay, that's this is a commonly asked question, so therefore I have to repeat a couple of times. So supposedly this same HLA molecule and T cell recognize it, cancer cell as a fighting back mechanism express PD-L1. So therefore, this T cell which activated come to the cancer is going to die. So then antibody is blocking this. So this is approved for many types of cancer. And CTLA4 antibody is approved melanoma. And then, but the PD-L1 antibody is approved for lung cancer, bladder cancer, any kind of cancer, meaning that this is a general mechanism. All right, why if a melanoma patient doesn't survive from that, It's a challenge, right? Next one, please. All right, just a clock. And then idea is combination is better, right? But this slide did not show the toxicity, but the toxicity is also increased. So roughly combination skin melanoma 60% response rate, but the 60% toxicity rate, severe toxicity rate. But once a response is seen, that's durable. Now 2 years, 3 years, 20% to 30% patients still survive skin melanoma. So it was considering, Right, next one. again, this is all kind of toxicity, as I mentioned. So, and the problem for the eye melanoma is response rate is much lower, but toxicity rate is the same. So, how we justify that? But in some situation we have to do it, because that is the only way to do standard of care. Okay, next one, please. You see, this colitis and skin rash, Stevens-Johnson syndrome, and pneumonitis, pituitary inflammation. So if you have to call the ipi-nivo combination, you need to go to the center because this is potentially very toxic. But there is a 1 in 10 patient had response. Okay, once it's happened, it is durable. Next one. Okay, then these are kind of markers that predict the response. The most important thing that I want to just emphasize, in other words, everything is opposite in eye melanoma. Okay, so I have to keep time. Yeah. So for example, Mike, here you go. Mutation load. This is how many kind of mutation tumor has. Usually, if there's more than 10, 20, it's a good, because immune system already see it. So there are many T cells which recognize it. Eye melanoma, close to 0. Okay, there's only 4 or 5 mutations we can memorize, right? G protein mutation, BAP1 mutation, SS3, but only 5 or 6. In addition, there's many small mutations that is not important. So mutation load is low, so that's one thing. The other thing, PD-L1 expression in the tumor, then interferon gamma related gene expression. These are kind of evidence that tumor cells are attacked, right? So, and then next slide, if possible. Yeah, okay. Actually, PD-L1 expression in the tumor, eye tumor, metastasis to the liver is almost 0. So, and then interferon gamma inflammation is almost 0. So that's the reason why immune system is not working at all to begin with. So and then why you remove the immune checkpoint blockade, and then it's not going to work because tumor cell doesn't recognize, T cell doesn't recognize cancer, or T cell is suppressed already. So that's a challenge. Why that happened? One of the reasons I think it's a liver. Liver, is getting all toxic substance from the gut. So they have to adjust, how immune system respond. So as a result, liver is kind of immunosuppressor organ. So if cancer cell there, they're happy because T cell cannot survive well. And as I told you, very hypoxic environment, and also a lot of kind of amino acid depletion, like a kynurenine production, tryptophan reduction. So many reasons, liver is not a good organ to target by immunotherapy. All right, next one. So my fellow check PD-L1 expression in the liver and then lymph node and others. So this is a uveal melanoma, I think, liver 0%. So immune system, this is kind of a PD-L1 is fighting back mechanism in general. So therefore, they are not expressed because they are happy. They don't need to express it. So same thing happened, skin melanoma. If skin melanoma metastasis in the liver, it's 0%. So this indicates that this is not only skin melanoma, eye melanoma difference, but also the organ is bad. Okay, so but skin melanoma has much higher response rate in general. So low mutation burden, low tumor neoantigen expression, lack of PD-L1 expression, that indicates that this tumor immune checkpoint blockade is not going to work. So we have to do something different, or in combination. Wait, next one. Sorry, so many tiny words. So what we can do, the couple things, what we are doing is just bring a cell into the tumor, so-called bispecific molecule fusion protein that we're talking about, immunocore, or culture the tumor infiltrating inside, believe that they remember the cancer, then culture the expand and infuse back. A more popular approach in different type of cancer, especially leukemia lymphoma, is CAR T. CAR T is engineering the T cell to express tumor recognizing antibody. not the T cell. The difference is quite significant. So the T cell put the CAR T in, and then leukemia lymphoma pediatric patient cured. So it's approved right now. So now fields coming into this solid tumor, melanoma, including melanoma. There are many clinical trials now starting, but the problem is it's attacking cancer. The lymphoma is kind of floating cell, like leukemia floating cell. There is a castle, suppressed, surrounded by immune suppressor cells. It's very difficult to attack. So, but the researcher is thinking of, how to block or kill the soldiers first, and then bring T cell into the castle. Okay. And then aberration, checkpoint blockade, So what we are doing here, probably next one is okay. I think that this slide is going to be available on the internet sometime. I don't know. Yeah? Okay. So I'm sorry, it's so tiny letters, but there are many 1 hour talk about how to change the weight, but can you just move it? Okay. So this is kind of one of them we developed. It's more than almost 20 years ago. We are proud of us because 20 years ago we thought about that. Liver is very immunosuppressive. Why don't you just go into the liver and kill it? So this is immunoembolization. Next one, please. So basically, we put the catheter in this, and then inject the immunostimulant, and then put the embolic agent to kill the cancer. Immunostimulant go into the cancer, and then cancer is killed not by chemotherapy, by the ischemia, no oxygen supply. Then immune stimulant can attract the immune cell to stimulate immune system. So this is immunoembolization. So this we know that the chemotherapy doesn't work. So we start from this, and it's good for the small to medium sized tumor. A big tumor is toxic, also doesn't work well. So, but again, median survival, we don't like survival, but overall, close to 2 years right now. And then 15%, 1 in 6 is 3 years survival. Some of them 10 years. So this itself is, again, eventually progress, so therefore we have to give chemotherapy, anything. But this is kind of very good treatment to start with, to kill this guy in the microenvironment where the immune system is very difficult to attack. Next one. This one example. This tumor getting much smaller after second treatment. All right, and then we are combining this with ipi/nivo. So we are providing the antigen to immune system. Hopefully, ipi/nivo at a different dose, a smaller dose, help. Right now, this adaptive immunotherapy is culturing something outside and bringing back. Next one. It's going to be very difficult, but again, lac cell, the general stimulation, CAR T is there. Dendritic cell vaccine approved for the prostate cancer, but not for the melanoma. Here, TIL. So basically, cancer is removed, and then I'm not the right speaker to talk about that, okay? And then if you have any question, very specific question, you should talk to Dr. Kamura. But I'm not going to explain general thing. TIL, and they extract the tumor, and then these lymphocytes should recognize cancer because there should be some reason why they are there. And then hopefully they, in hope that these cells can go back and then send it back to the body. The current challenge is this is not simple. You have to wipe up patient immune system first because patient immune system is already very suppressive. Injecting these cells is not going to suppress it's going to be suppressed very quickly. So therefore, high dose chemotherapy and high dose IL-2. So probably I'm out. Maybe somebody who was in the 40s, 30s, maybe, fight for their life, can do it. But again, even patients in the 30s, they're sick. They're sick for a while, yeah. But again, this is one approach. It is shown some efficacy. So I think this is one approach that you might think of as immunotherapy, but this is a lot of work. Next one. Again, this is miracle response in skin melanoma. And you see multiple dots disappear. Again, this is a very strong treatment for the cancer patients, and then actually result is dramatic. So, and then Dr. Rosenberg say maybe 30%, 40% response rate, dramatic response rate, and then Kamura maybe humble enough to say maybe 15% or 20%. I melanoma is less efficacious in general. But there is some response in this approach. TIL, right? Next one. This is kind of briefly, not coming yet to the eye melanoma field, but just making a specific antibody to recognize cancer antigen, and then put into the immune cell. Next one. The approved one is a CD19 CAR T cell, B lymphoma cell, or B leukemia cell, B cell leukemia, express CD19 antigen, and then this T cell express antibody, chimeric antigen receptor, then recognize it and kill it. So this is targeting on the surface molecule. So a similar approach has been started for melanoma by using a melanoma-specific antigen on the surface. The again, challenge is we are sending a soldier to the area with many killers. So that's one thing. Right, coming.
So it's a spy.
Yeah, spy. Yeah. Many put the kind of molecule not to die. Okay, I'm strong. Give me a bazooka. I'm still alive until kill the cancer. Yeah, research is progressing. So I think it's going to coming sometime soon, but not today. And I don't think anybody start eye melanoma study yet. Next one. This is a molecule, and again I have to tell again I'm a PI of the Jefferson site. So, and then let me explain again. This is so-called T-cell receptor, and this portion recognizes peptide on the surface of the MSC molecule HLA2. So therefore, if patient doesn't have carrier molecule structure, doesn't work. So then this T-cell receptor doesn't exist in nature. They found the T-cell receptor recognize melanocyte protein GP100, and they mutated in the computer technology. Very brilliant people in UK. And then affinity increased significantly. So therefore, this is like, we call it magnet, immunological glue or magnet. This bind to the cancer. If cancer express the GP100 peptide on the surface, it's like a very strong, sticky, molecule here. Then this tail, it's kind of an interesting cartoon, but this tail is antibody against T cell, CD3 cell. So I think a mechanism is first, this molecule stick to the cancer cells or melanocyte, melanin producing cell. Then catch the people nearby, especially if they express T cell marker CD3. So T cell cannot go. And then binding T cell receptor in a very solid phase activate T cell. So now T cell have to release those toxic granule or kill it. So until that happens, these cells stay there. All right. There are many questions, arguments, debate, but I want to show you some efficacy. This is a very intelligent approach. CAR T, just T cell receptor, antibody on the surface, and then they have to manipulate T cell, but this is a very small molecule, doesn't need any T cell. Just, infuse that. Next one. So basically, lymphocytes come to the tumor site, and then in this case, very interestingly, to skin. Patient developed a very strong skin reaction, and then I think this is lymphocyte. This is a post. We know that they are doing some job in somewhere. Yeah, significant drop in circulating lymphocytes, and that usually go to the tumor or skin. Next one, please. So this is one of the, again, it's biased, okay? We are showing, a best picture. But this is a cancer. and this after treatment. All cancer is dead, even in the liver, because we don't care, but still liver has immunosuppressive environment, so therefore maybe not totally efficacious, but this is one patient whose tumor disappeared. Next one. Okay, I told you there's no immune cell, and then after the treatment looks red. Looks red means these are all immune cells. So after infusion of the molecule, immune cell are in the tumor in the liver. So this is evidence that this molecule is stick to the cancer cell. Next one. And then on the other hand, this molecule also kills the melanocyte. So patients have to be in the hospital for the first 3 treatments because significant edema, high fever, rigors. And then after several treatments, they lose pigment because this molecule work on the yeah. And then, but around this time, patient just come and go. Another thing is every week. I feel guilty, if I suggest this to the people in, Texas. At the beginning, there's no other site, so they have to come. But now we have like 20 sites. So next one, please. And then this is a phase 1 study, and prior treatment is like up to 4 treatments, 5 here. There's multiple patient who has failed multiple treatment, and now most recently protocol change. We can only accept patient who has failure to 1 systemic and 1 local liver treatment. If patient has 2 systemic, they are not eligible. But we have to wait until medicine is approved, but they have to do something else. Okay, next one. Toxicity, could you click? One more time? Yeah, here you go. All toxicity is like, most patients have some toxicity, but these are all skin toxicity, most likely. And also, click one more time. They're tired, fever, sometimes blood pressure drop, but we never send a patient to ICU. Next, one more time. Yeah, here go erythema, macular rash. So because this GP100 molecule is expressed in normal cells, normal pigment cell. Interestingly, luckily, patient doesn't have any eye symptoms. That's a scary thing that I saw at the beginning. If this is so efficacious, they may lose eyesight because pigment is in eye. So it didn't happen. Probably because some distribution issue, but no significant visual toxicity. Next one. This is a response. These patients responded, but I have to admit, response rate shrinkage rate is not so high. And so we have to have improvement, but overall response rate is like almost 70. Most of the patients have stable disease. All right, and then issue is how long. Next one. Okay, I think you can skip it. Next one. Okay, I think, yeah. One thing that we don't know yet, if patient is on this study and then receive the ipi/nivo later, immune checkpoint blockade, as I told you, ipi/nivo combination 10%, we have a dramatic response. This is after failing, immune checkpoint, IMC-GP100, they received the, ipi/nivo, clear. So somewhat this treatment is kind of a presetting cancer patient, melanoma patient to have more immune reaction. And the ipi/nivo is going to be facilitating the further response. But again, it's a so small number, so I have no position to advertise this, but we're carefully collecting more patients. In other words, do this first, and then if some reason grow through, you did. Next one. This is a kind of Dr. Carvajo's patient. This is pre and post, much less activity in here. After failing a GP100 and then receive ipi/nivo. Next one. Yeah, this one is also, we have to think that carefully. These are all patients who participated in the phase 1 trial. Phase 2 also included 42 patients. As I told you, majority patient has no shrinkage, but stable. And then overall, they survive very long. Yeah. This is a different study which have like a 400 or 800 patients together, clinical trial, melanoma metastasis. This is actually standard curve, like 1 year survival is 30 to 40% range. Compared to that, this is going to be very extended. So the patient has suffered for 3 weeks because out of swelling, fever, up and down. After that, it's kind of very easy approach, and then they lose the pigment, and then they tend to stay in the study, a weekly study. So that's a very time consuming, but it's, I think, worth doing. Next one. Currently, this is one that we did. Next one. This is an ongoing parallel study. I didn't tell, but upper stage, like a phase 2, phase 3 study, FDA government say, compare to. That's pain. Compare to, in our institution, ipilimumab. Patient is randomized into 1-to-2 randomization to either standard care, ipilimumab, or study medicine. So this is ongoing, and then we are hoping that this trial, like I showed that, may trigger the FDA attention. This is a rare disease, why don't you give this approval temporarily, because so many patients waiting. But rule is rule, so I have no way, to tell. But it's a two study. One is patient who failed previous treatment, one systemic treatment, one local treatment is maximum treatment, and then study is going to be closed maybe February. I think Immunocore people here to answer. And the second trial is ongoing. This is a 2-to-1 randomization, either study medicine or investigator choice. So this is ongoing. I think that hopefully this medicine is going to be available sometime soon. And then we are moving on to different molecule, antibody fusion protein, Tcell fusion protein. So our dream is, you come here, I have a drawers. HLA typing is done. Okay, this is medicine maybe yours. HLA-A3, maybe this medicine, And then by that time, hopefully we have some way to improve the response rate, I think I have 7 minutes. All right. You have any question? Sorry.
So,
yeah.
If somebody is HLA-2 negative, they can't have this treatment.
Doesn't work.
Is it possible to have somebody who is HLA-2 positive grow T cells for the people that aren't?
All right. So very important question, but if somebody give you a cell to you, what's happened?
My immune system will
Reject quickly. So therefore, even transplant, they have to have a match. This is so-called MSC match. So therefore, issue is HLA-A2 is required for the protein recognition. So if somebody else had HLA-2, it doesn't work well. So-called allogenic infusion. One way is just wipe up all immune system and put that in. It's tough. Still some rejection process. Cell cannot.
Flood it enough with.
Yeah. Also recognize healthy cell first, and then significant reaction. And most likely, infused cell is going to be defeated, eliminated, because you have tons of immune cell to attack on the foreign cells, right, by infusion. So, yeah. Okay, good thought. Yeah. Anybody else?
I'm on Keytruda. What do you think about that one?
Keytruda is very good medicine, and then work for roughly 30% skin melanoma patient. And we have a Keytruda went on a study for melanoma a little bit. Didn't work well. So the number is 3.6%. But it's much less toxic. So, but I would not recommend single agent Keytruda. It should be combined with something. You know,
Should be
combined with something.
like a trial. I had
Yeah.
radiation done in my liver, and then Keytruda, because the doctor believes that there's.
Yeah, so that's one thing. You know, radiation kill the cancer, release antigen. You know, immune system is somewhat activated. You know, so Keytruda may help because doctor like it because much less toxic.
Yes.
But efficacy issue, you know, whether that is increasing actual efficacy, I'm not, be honest with you, I'm not 100% sure. But be honest with you, we are doing the same thing. You know, immunotherapy, immunoembolization plus Keytruda, we did that. But it's not so impressive, so therefore now we are doing a triplet. You know, immunoembolization, Yervoy, and Nivo. It's a very, you know, heavy duty. And then Dr. Miner from West Coast, we have a site, radiation, radiosphere, plus Yervoy, Nivo. So we're doing combination. And then if we can combine PD-L1, Keytruda plus something to show something, that's the idea. But we feel that maybe need to be a little bit more aggressive, you know. Yeah. Again, I have to admit, sometimes we did that before. It's easy and approved. So, okay. But a single agent doesn't work.
Thank you.
5 more minutes. That's good. You okay? Oh, go ahead. I'm sorry.
Just curious if any information has come forth about the people in Auburn, Mississippi, the cancer cluster.
Oh, I am going to talk right now. 2 o'clock.
Okay.
Maybe different room. Again, conclusion is not sure. Be honest with you. We see, kind of clinician feel something. This is something wrong. Then the patient feels same thing. Why my classmate has the same thing? But government say, okay, statistically not significant. We are not going to call this cluster. So, but we can talk a little bit. Okay. Thank you. All right, 5 minutes done. So you have time to go to bathroom. Thank you.